Good evening and welcome to the New York, New Jersey Pain Symposium presenting Getting Back to Work After COVID-19. We will start the program in just 2 minutes to allow some additional people time to log on. Thank you for joining us, and we will start in 2 minutes. Good evening, and thank you for joining the New York, New Jersey Pain Symposium, Getting Back to Work After COVID-19. We are so excited that you have joined us this evening. We will start the presentation in just 1 minute to allow a few more people time to log on. Again, thank you for joining us. The presentation will start in 1 minute. Good evening, and welcome to the New York, New Jersey Pain Symposium, Getting Back to Work After COVID-19. We will start the presentation in just 30 seconds. We are very glad that you have joined us this evening and look forward to starting the program in just 30 seconds. Good evening, and welcome to the New York, New Jersey Pain Symposium, Getting Back to Work After COVID-19. We are thrilled all of you have taken the time to join us on this webinar tonight. We have an incredible program planned this evening with 2 amazing panels. I would like to introduce our moderator, Dr. Sudhir Dewan. Dr. Dewan is president of Advanced Spine on Park Avenue. He is nationally and internationally recognized as a key opinion leader in the field of interventional pain management. He is the immediate past president of ACIP and the founder and chairman of New York SIP and the New York, New Jersey Pain Symposium. Thank you again for joining us this evening, and I'm turning it over to Dr. Dewan and our moderators.
Thank you, Michelle, for kind introduction. And I'm so honored to have Tim Deere and Chris Garibo to join us on this webinar. And it's really our honor. Both Tim Deere, I'm sure you all know him, internationally renowned interventional pain physician who has put Charleston and West Virginia on the world map. And we all love him because he has contributed so much for our specialty. Dr. Garibo, he is the chief and professor at the NYU, professor of anesthesiology and pain medicine. He is the course director of New York, New Jersey Pain Symposium. He is the recipient of the Outstanding Physician Award of the 2019, and it's our pleasure to have him as a moderator on the webinar. We also have a backup standby expert, Jennifer Kirschenbaum. She is not going to be speaking, but she is a standby for legal questions. So if you have any legal questions or clarification you need, please direct question to one of us and we will send it to Jennifer and she will come on to join us. With that, I'd like to start the panel and I would like to introduce our first speaker. So first speaker is Dr. Soin. It's my really honor and pleasure to introduce Dr. Soin. He is very young, but he's a scientist, he's innovator, he is a president-elect for ACIP, he's president for OSHIP. So if you look at his CV, it looks like it's a book. So rather than going on to his CV, let's give him a chance to speak. So Dr. Soin, please take over.
Yes, thank you very much for the kind introduction, and I really appreciate it, and honored to be with this great panel. What I want to talk to you a little bit about is some of the financial challenges to run your practice, and we're going to talk about some of the business and economic impacts and some tips for survival. I made these slides yesterday. Going over some options to capitalize your business. As you know, ultimately you are responsible. What I'm presenting is just my opinion. Always good to consult with a lawyer, banker, and an accountant. So let's move on to some updates. And we're going to talk about our recent updates or stuff that's occurring now, because this is changing every day. And starting with the Medicare advance payments. Yesterday, or the day before yesterday, April 27th, they actually suspended the Medicare advance payment program. And that was the program where you could get essentially a bridge loan that was interest-free from Medicare, and it was based on your future payments, and you could use a formula calculating your previous payments, going backwards to calculate a way to get payments deposited immediately that you could use to keep your practice around. That program was used extensively, and not only by small physician practices, but large hospital networks. There were some hospital networks that I heard of that were asking for advance payments of $30 million. And so this program, funding was quickly put in jeopardy, and the government realized that so many people were asking for advance payments, they actually had to suspend the program. Some of the MACs were faster for processing than others. So for example, in Ohio, we had a very responsive group that was processing these payments within 3 days of filling it out. In total, $100 billion was sent out, and when they hit that $100 billion threshold, that's when they canceled the program. But as you know, if you got one of these programs, the money must be repaid within 120 days after you receive the money. It's an interest-free bridge loan, and it is paid back based on your future claims, where Medicare essentially will process the claim, but they won't give you money. They'll just deduct it from the amount that you took. And we'll move on to the next slide, please. If you can go back one more, there you go. The next thing is the HHS Stimulus, and this is important for you guys right now. This is a second round of money, a total of $20 billion. As you may recall, the first round of money, $30 billion, was administered automatically. So for those of you who already were enrolled with EFT with Medicare, you may have seen that you got this stimulus deposited directly into your account. Now the second round of money is different, and it's different because there was a lot of complaints with the first round of money. People were complaining that institutions, hospitals, physician practices that really didn't deserve to get money got it because they didn't discriminate. Everyone basically got 6.1% based off of last year's collections from Medicare deposit into their account. So this time you actually have to take action, and there's the website link right there. You have to go to the hhs.gov website under Coronavirus CARES Act Provider Relief Fund. You could actually even just Google that and it'll pull up this link. When you click that link, you click on the general distribution portal, and you have to log in to do some attestations. You have to attest and provide some information to them. You have to show your gross receipts or sales or program service revenue as submitted on your federal income tax return. You have to provide your estimated revenue loss in March of 2020 and April 2020 due to COVID. That's important because that's what's going to be used to calculate the amount of money that you'll get. You want to do this because this money that you get is completely forgivable. It's a grant. There's really no payback, so it's important to get it. Now, when they talk about revenue loss, I want to tell you something. It's not necessarily what you collected. It's based on an estimation of the claims that you had in March and April. Because if you do how you collected, well, a lot of us, the billing trails back 4 to 6 weeks. So in March of 2020, we're going to see no impact because in February, most of us were operating normally. So you have to do some math, and it's just an estimation. And to be honest, for smaller practices, group practices, and even physician practices, I don't know how granular the government's going to get with those estimations. Some of the large hospital networks, for example, there's one in Dayton, and we're not a big town, Dayton, Ohio, but one of the hospitals said that they anticipated losing $35 million. And I think something like that, they're really going to have to get granular with their details. You have to have a copy of your most recent filed federal income tax return. Since the taxes were deferred from April to July, a lot of people are submitting their 2018 reports. Of course, if you have your 2019, that would be preferred, but the 2018 are being accepted. And then you have to list your tax ID numbers. Your Medicare number has to be available, and you have to list the amount that you got on the first stimulus. Next slide, please. The first round of stimulus money that you got, you do have a step to take. You have to go to this website, covid19.linkhealth.com, and you have to complete 4 steps. You have to determine that you have to attest that you are eligible to receive the money. That means you are actually operating and seeing patients. You have to insert your billing tax ID. You have to verify that you got the money, and then you have to attest that your practice was impacted due to COVID-19. That process is almost as quick as it took me to explain it to you. It literally takes about 2 minutes, but make sure you do it because technically by rule, they could come back and claw back the money. So please complete your attestation if you receive the first round of money. Next slide. So reopening guidance, you know how to open and be safe. Ohio has an example. We have 5 protocols for reopening, which we're reopening March 4th, and they're saying, look, no mask, no service, no work. So everyone has to have a mask. It's not your job as an employer or business to provide the mask, but you do have to ask your patrons to wear a mask. You have to conduct daily health assessments, assess fever, symptoms, etc. Maintain good hygiene, washing hands, clean and sanitize, and of course, limit your capacity for social distancing. I know a lot of other panelists will be talking about this. From a business standpoint, though, if you don't do those things, you don't want to see repercussions of being shut down or sanctioned. Next slide, please. So reopening your business, you know, some things that are important is exposure, right? So in Ohio, they said you have to immediately report to the health department if there's an exposure, and they're telling employees that there's an anonymous tip line. So if your employer is not following the rules, they can whistleblow against you in the state of Ohio. Of course, I don't know how New York is, but it's just important to follow the rules. And, you know, I've listed some other things in Ohio as an example. I don't want to spend too much time on it because, of course, we're in New York, but I'm just using that for reference. The important thing is to try to stay capitalized with your business, monitor your cash flows. Because we were all closed in April and a lot of March, you're really going to start to feel it in June and July. So try to stay as lean as you can for the next couple of months, because you may be cash rich now, but you're going to burn a lot of cash and not have a lot coming in over the next month or two. Next slide. I created this procedure suite and ASC checklist, and it's basically like a toolkit and a checklist that are some tips. You know, do you have enough inventory? Are your drugs not expired? You know, have you informed vendors that you're reopening? You know, have you informed patients? Do you have social distancing protocols? Is your RFA machine working? Have you checked your C-arm? All of these things, and we're doing that in Ohio because if the Ohio Department of Health comes in and says, hey, you know, what have you done to prepare for coronavirus or reopening? I'll say, guess what? I have this checklist and I did all of these things, and it's just a document that I have. So I made this checklist. We're actually going to be pushing it out to ACIP, and I think Dr. Dewan's going to end up pushing it out to all of you at New York and New Jersey SIP for everyone to see as well. It's something to consider using. We tried to make it universal for everyone. Thank you.
So Emil, let me ask you a question. And the question really is, I think, very important. And that is, you know, we have a lot of patients scheduled for procedures. And I have about 50 patients who were scheduled for stem trials or DRG or permanent implants. And now they're going to get called to come back in for elective surgery, because in West Virginia, much like Ohio, we're opening up next week. What advice do you have for our staff when they talk to the patients? Is there things they should tell them about, you know, the process, about the risk? What type of advice would you offer to that patient who's getting called back saying, we're going to do elective surgery now?
A couple of things. You know, I think each state Department of Health, and there may even be some federal guidelines on what you need to do to reopen a business. And I think it's important to follow those. So in Ohio, they are saying that they recommend wearing masks. So I would tell the patients that. I would also inform the patients that if they have any symptoms, they're going to be asked if they've had these symptoms of cold or flu over the last 14 days. We're going to check their temperature to see if they have a fever, and they're going to ask about travel history or exposure to other patients who have tested positive with COVID. That's actually a requirement to enter a place of business in the state of Ohio, and it's probably good advice to do universally because it's very easy and quick to do. So it'd be important to tell those things to your patients. It's also very important to maintain safety for your staff as well. And in Ohio, they've really marketed this anonymous tip line saying, hey, if your employer is not following the rules, please tell us, we want to know. The last thing you would want is your business to be shut down. But most importantly is to protect yourself as an employer, because if you get corona approximately 1 month, if you think about it, because you're going to be sick for about 2 weeks, and then you're going to have to be self-quarantined for another 2 weeks. So it's important to protect yourself.
No, I think that's great advice, and thank you so much, and thank you for that time. And we'll look forward to hearing you later in the question and answer session. And as my neighbor in Ohio, thank you for all you're doing. Greatly appreciate it. Our next speaker is going to talk about really a very important topic. And Dr. Shalini Shah is a very impressive physician, program director and vice chair at UC Irvine. And she's going to talk about really something I think is critical for our future, and that is training fellows and residents. And I've had a lot of those fellows and residents call me. They're very concerned about their training, and thank goodness you're here to give us guidance. So Dr. Shah, it's all yours.
Thank you. All right, we'll go to, yes, the first slide. So, over the last few months, we've been talking about what happened to the fellows, how they've been repurposed, what the ACGME's response was to and what the fellows' rights are, because as you can imagine, they've missed out essentially 4 months out of the 12 months of training. And so for those programs that just weren't that robust to begin with, that's huge. That's huge in terms of procedural volume, E&M, diagnostic opportunities, all of that. But now, as we're talking about going back to work, there's an entire new discussion in place. So let's go to the next slide. This was an article that was written in Stat News a couple of weeks ago by a Harvard professor of medicine. And he says, essentially, should we consider delaying the start of residency programs? June, July, when the residents start to matriculate, they don't have the amount of supervision that we normally would have given to them because now we're in a pandemic status. And because of that, should we consider holding off on the new medical residents and pushing the start dates down to September or October instead? So as you can imagine, this garnered a lot of press, both primarily from the fellows and the residents, but from some program directors as well. And they have queried the ACGME, and we haven't heard a response from the ACGME whether they want to push back the start dates of our training programs. But here's a few things to consider that's on a lot of people's minds, and it's not being answered so far as we know from the ACGME or from the local GMEs or the DIOs of various programs. And that is this. Look, in about 3 months, 2 months, we're going to have massive movement and migration of medical students, residents, and fellows in this country. Those that were in New York doing medical school will now come to California, vice versa. Those who were in high-risk areas will go to low-risk areas and bring potentially that virus. It's massive migration to the extent that we haven't seen before. If you think about how many trainees that we have from PGY 1 all the way up to PGY 7 or 8 in this country. So the question is, should COVID testing be part of the onboarding process? As we matriculate these new residents and fellows in, is it reasonable to ask them to have COVID negative PCR testing or serology testing prior to matriculating as part of the OC Health process? And we don't have an answer on that yet, but this is a serious consideration that most programs and most program directors are considering, particularly if you think about it. Some of the anesthesia programs are 10 to 30 residents a year that are coming in new from all over the country. And I think it's a fair consideration to really think about as we migrate across the country that perhaps we should be doing some COVID testing, especially if you come from a high-risk area. The other thing to consider that most programs want to, or at least think about considering as fellowship programs, is maybe consider bringing on your fellows as part of medical staff. What we saw during the pandemic is a lot of repurposing and a lot of last-minute pushing the anesthesia fellows to do ICU work, ER work, or OR work. And they couldn't do that because they didn't have medical staff privileges. So it was a very fast medical staff privileging process that wasn't necessarily very safe or not entirely fraught with due diligence. So one consideration would be to bring in your fellows, but also give the medical staff privileges to do anesthesia if they want to or if they need to, especially if we anticipate having a resurgence in the fall or winter. There's a consideration amongst the fellows that if they feel unprepared to graduate and they want to stay on for another month or two, what about the competition with the new incoming fellows? Will they steal my procedures, or the new fellows will say, the old fellows are stealing my procedures? The good thing is that about a year ago, the ACGME removed minimums. and this is either a good thing or a bad thing, depending on your view or take on it. But essentially, they remove the minimums that are needed for graduation. For example, 10 neuro-mini mental status exams needed to be performed to get neurology credit. Now, it's entirely up to the program and the program director to say you have competency. So there are no minimums. So those fellows that are worried about obtaining minimums or having the old fellows steal their new procedures or the new fellows steal procedures from the old fellows, that's not really a concern anymore. And the very last thing is educational content. I don't know about you guys, if you have to homeschool your kids with Zoom, I don't know how effective that is in the long term. Having PowerPoints delivered through Zoom for an entire year for these fellows, or at least 6 months of the year, because of social distancing, I'm not sure how effective that content will be or how engaged we can make these fellows. So that's one consideration. I don't have an answer for that, to be quite honest, on how to deliver more educational content, but this is going to be a theme. As we see conferences postpone themselves or even cancel out together, a lot of the conferences are considering going virtual or having at least a component that's virtual. And so how do you engage people virtually? Do you make breakout rooms? Do you, how do you do networking? Because a lot of the times when you go to conferences, you're networking. How do you network online? So these are some of the considerations that we should be thinking about.
Yeah, thank you, Shalene. Very valuable considerations. So today I got a phone call from 2 fellows of mine, and I've been talking with fellows from across different institutions that have contacted me being interested in a job. And one thing that I asked them, and one thing that my fellows told me, is that I didn't get enough experience with my procedures. I feel like I was shortchanged with my technical experience, with my didactics. We have 2 months left. How do we make it up? What's your advice to us?
You know, if they are still closed for business, you have to utilize your drug companies and your industry companies. I think that's going to be valuable. Wait till you graduate so that you can enroll with these industry cadaver courses, or even at conferences. I'm hoping that a lot of our societies will be pushing pre-fellows or at least very low cost fellow education for cadaver courses.
Sure. And going forward, what are the long-lasting changes that you see to pain medicine fellowship training that are going to occur as a result of COVID-19?
I'm hoping none. I'm hoping none of them are long-lasting.
Lectures by Zoom or anything else that's virtual, do you think any of that is here to stay?
Yeah, I think virtual engagement is here to stay. I personally like the fact that a lot of the meetings I can have at the grocery store, you realize what's really needed to be in person and what's not. So I'm hoping that virtual stays as a part of our lives. But I hope also the fellows realize that you don't need to be physically connected to someone to get engagement, to connect to someone, or to be to network with someone. There's a lot of other ways besides being physically close to someone.
Okay, thank you, Dr. Schaff. That was very valuable. Looking forward to having you come back for our subsequent questions. Now I'd like to introduce a good friend of mine from New Jersey, Dr. Waska, who I've known for many years. Him and I, along with Sudhir and other colleagues, have put together the New York, New Jersey Pain Medicine Symposium. Dr. Waska has extensive training in physical medicine and rehab, interventional pain medicine, and the business aspects of pain medicine. And he will talk to us today about the workflow modification for the new normal post-COVID-19. Scott.
Thank you very much, Chris. I had to switch my microphone. Can you hear me okay?
You sound good.
Thank you. So we're talking about, sort of the, the practical aspect of returning to your office when it's appropriate to use a telemedicine, when it's appropriate to do a physical exam, when it's appropriate to do an intervention, and how you can kind of navigate some of those obstacles. Can we go to the next slide? Michelle, can you advance to a slide, please? So the goals for reopening the office are, of course, there's an economic impact on all of us, and we want to service our patients. So our goal is to provide a responsible pain management service for our patients in the safe way as possible, and to triage those patients for appropriateness. Obviously, we want to reduce impact on the emergency department. We want to establish a safe environment for ourselves, our patients, and our staff. Minimize disease transmission with PPE. Obviously, we're seeing pain patients, but we're still screening for fevers and symptoms so we can send those patients to the appropriate treatment location. We need to train our staff to screen for us. Our staff needs to be sort of our eyes and ears before patients come into the office. And we need to determine which patients are more appropriate for a telemedicine visit. Not every patient needs a physical examination. Some practices are very procedure heavy, and some are more of a mix of procedure, medication, musculoskeletal evaluations. So certainly we can see more patients through a telemedicine experience and be effective in diagnosing. And so part of our job and the workflow change is to determine which of those patients are more appropriate. So let's say we've determined that a patient does need to come into the office to evaluate for a procedure, perform the procedure, or do a clinical exam. Then we have to adjust the physical plans of our workflow and our office to keep that as safe as possible. Can you advance to the next slide, please? So we're essentially turning our office into a triage. This is going to start with pre-screening, and that comes to training your staff on the right questions to ask. So obviously, we want to identify patients that are higher risk, more advanced age, comorbid conditions, smoking history, diabetes, obesity. That can be done simply with a questionnaire that you hand your screener that's calling the patients for appointments and say, listen, you have to ask these questions. And if they are positive, that patient should not come in for an office in-person visit unless there are extenuating circumstances, and you have to pre-screen that visit. You obviously want to prioritize more urgent situations as opposed to more casual situations. The staff has to screen for fever, cough, shortness of breath, and you have to instruct your patients to bring their own mask, which is very important. So let's say your patients have passed the pre-screening process. Now it's time to check them in. They're coming into your office. So the check-in process really should be different than it used to be. You want to keep people out of your waiting room and move them in and out of your facility quickly and safely. You should have your patients checking in by phone from their car in the parking lot, not at the front desk. And you may have to even install a dedicated line or phone line to your reception area so that process is not interrupted. So patients should call, say that they're there. They're told to wait in your car and we will call you back when it's your appointment time. And those patients should stay outside in their lobby and essentially be brought, if possible, straight to an examining room and bypassing the waiting room, or at least minimize the time in the waiting room. Masks should be available if the patients fail to bring their own. You would ask family and friends not to accompany your patient into the clinic, but to stay in the car if possible. You'd also like to try to leave your doors open. You can prop them open if the weather is nice. You want to try to avoid contact with door handles. And once into the facility, you'd like to try to minimize contact with paper, pens, and writing utensils. So if you are a practitioner that uses a intake form, try to have that available for download, and patients can fill it out and bring that in with them, as opposed to filling it out there. You'd like to try to use a non-contact thermometer, which is available, and screen your patient's temperature before they come into your suite. So you may have to have a point person that meets them outside in the lobby, checks their temperature, and then brings them into the examining room. Your waiting room, you may need to install plexiglass or some kind of a physical barrier for your reception area. You want to try to disinfect your waiting room more often, more frequently. Put up signs and posters that are easily available for purchase on hygiene and cough etiquette. Have available mask tissues, waste receptacles, alcohol-based sanitizer, assuming you can get the sanitizer, it's hard to get. And try to get people straight into the exam room and bypass the waiting room. If you must use your waiting room, remove all reading material. If you have a choice between armchairs and non-armchairs, try not to use the armchairs, and have less chairs in the room and keep them 6 feet apart. Once patients come into your exam room, try to remove items from the table area. So your reflex hammers, your models of whatever device you're going to be educating about, try to put that all inside the drawers and inside the cabinets. Leave the door open. You'll probably be standing in the doorway talking to your patients. Disinfect that examination area more frequently. And once, if you decide that you need to do a physical exam, obviously put on the appropriate PPE, quick exams, and then try to get the patients out fast. If you're used to giving your patient a piece of paper that they then hand to the reception area, try not to pass that paper back and forth. Either deliver it yourself, put it in a pile, have the patient out the door quickly, avoid the long goodbye lines. Just say, listen, leave, and we'll call you to set up your next appointment, as opposed to having a long line of people that are not able to keep that distance. So I think I'm out of time. These are just some of the more practical things to think about as you get back into the world of seeing your patients again.
Thank you so much, Scott. You really have covered almost everything, but I do have one question. How would your guidelines change if your patient is coming in a wheelchair?
So that's a great question, and the same applies to what about your patients coming from nursing facilities? You're talking about a higher risk patient. I think a wheelchair can be wiped down before patients come in. Obviously, anyone handling that patient should wear gloves. You can have a pass off from a family member in the lobby to a staff member who's wearing a mask and gloves to escort the patient into the room. And then you just want to try to avoid contact with the wheelchairs as much as possible.
Thank you very much. That's very well said, because nursing home patients are high-risk patients, and we are actually trying not to see those patients in phase 1. But if somebody has to be seen, then we have to take all the precautions. Again, Scott, thank you so much for your presentation. It was great. So now I have a pleasure to introduce my former colleague and very active member at the New York, New Jersey Pain Symposium. He is director for the ultrasound courses. Dr. Steve Eden is a clinical assistant professor at the Hofstra School of Medicine, and he's chief of the PM&R and interventional pain medicine at the Kyle Orthopedic Center in New Jersey. Take over, Steve.
Hi, thank you. Thank you so much for having me, Dr. Dewan. You guys can hear me okay, I'm assuming? Okay, so there'll be a lot of overlap between what Dr. Waska and I kind of will cover. A lot of this stuff comes from the CDC website as well as the ACIP website. So if you feel like the slides are too wordy and you want more graphics kind of things, you can find those on their websites, and that's at the end of this, and you'll see that. So my task here is really to give you some guidance as far as mitigating the COVID spread in your office. And as Scott mentioned, you know, with seeing patients, you also have to look at it from the perspective of now this is an office setting. So let's remove the patient aspect and look at it as a workplace aspect, and then adding in the risk factor of bringing in patients who could potentially be carriers of this, and then start spreading it amongst your office. So let's start with the workplace, and kind of the most important thing at this point is really educating your staff and your members that work in your office. The physicians, most of us, and even the mid-level practitioners like nurse practitioners, nurses, PAs, we're pretty aware about how to protect ourselves. A lot of what we were doing, aside from wearing a mask in the office all the time, was really being done. We're wearing gloves, we're hand sanitizing, we're washing, we're avoiding contact with patients when they're sick. So a lot of those things transcend into what we're doing today. But our staff themselves, the person who does the front desk, the out desk and whatnot, may not be as familiar with those things as we are. So you really need to provide them with education information. You need to encourage and instill a protective measures in the environment, as well as having the PPE and other things that are necessary to protect themselves. Because as Amal or Dr. Sohn mentioned earlier, people can file complaints, and from a workman's compensation aspect, and if you have questions about that, I'm sure Jen can discuss those. You need to protect yourself and your employees in this environment. You need to clean the area, make sure that it's sterilized, and If you have multiple offices, kind of come down to a skeleton crew or one hub. Make sure the other offices are clean prior to reopening them and kind of doing like a soft opening or expanding out to the sites as the demand is needed. Telework is very important. So anything that can be done via telephone, and Dr. Waska mentioned this, instead of having a long line at the checkout desk and having person upon person just hanging out and potentially, contracting or spreading or just being too close to one another, teleworking, or I'll just call you to make the arrangements for the office visit or for your procedure or so forth and whatnot. Make sure that your employees are aware of a flexible leave policy. As far as healthcare providers, if you have an exposure, we say 7 days of avoiding going back to work or self-quarantine, and as long as you're asymptomatic, you can come back. Limit non-essential work travel and non-essential work staff. So, you don't want to have too many employees around, especially in a time where there may be a lower volume of either procedural work or even office work, and have that potential of exposure. You want to cancel and limit work-sponsored conferences. So if you have office meetings, every quarter we have an office meeting with all 100 employees and we're all together. So that may need to be pushed off for a few months or done in this manner with a webinar or a teleconference. You want to implement social distancing in the workplace. So the break room, lunch breaks, just socializing amongst the MA checkout desks or where the MAs do their work, or the provider workspace. You want to make sure there's enough room. Each computer in most workspaces is about 3 feet from one another. So you may need more workspace as far as spread out in your office, or less employees present at one time so you can maintain that 6 feet of space. Consider regular health checks. So, if you're feeling feverish, make sure you have an ability to check their temperatures and whatnot. Maybe instilling a policy where patients are not just patients, but when staff come in, have their temperature checked or monitor for any symptoms that may be present or not. Next slide. So, and then evolving into the healthcare setting, not just the office setting, again, education and information. So one of the ideas that we did in our office was we downloaded the CDC art, we laminated them, and then this way they're in the office. We've even made handouts for the patients to hand off. So you can clean the ones that are in the office. This way you don't have to constantly change them. They can be cleaned with Sandy wipes. And that information is placed in the exam rooms with the patient, as well as around in the office setting as well. So it's available for everybody to see. You want to phone triage and telemedicine. You want to cross-train your staff. So you want to make sure that staff members are either are able to cover in case you are running down to a skeleton crew. Make assessments of PPE. You want to make sure that you have the necessary equipment for your staff and for your office help. You may not be responsible to provide for the patients, but if you can, like say somebody comes in and they don't have a mask, you're not going to turn them away if you have the ability to give them. But again, Amal mentioned earlier, it's not necessarily your responsibility to give that to them. Patient intake, as Scott mentioned earlier, make sure that there is a setup system where you don't have more than too many people as far as social distancing goes rules in your office waiting room. If paperwork can be done online, do it online. Have a phone check-in. Hang out in your car until you're ready to come in. Have someone call them, then straight to the exam room, and then straight to checkout, and then out to the their departure. Next slide. So moving on from mitigation to proper use for PPE. So PPE in an outpatient setting is a little more less stringent than it is in the hospital setting, obviously. We're not gowned up, we're not sealed from head to toe, but we still need to take necessary precautions. So you want to make sure that you have a mask available. The N95 may not be absolutely needed, but it is kind of the gold standard. So if you have the ability to provide that to your employees, it may not be a bad idea to have. You want most outpatient practices to be aware of what it is like to care for a patient that does not have COVID-19, or a patient if they arrive and potentially does have COVID-19. You need to make sure that the staff is trained on how to do that. The goal here is to limit the exposure to yourself to others, and others to you. as well as your staff, because now we're talking about a work environment and we need to protect those individuals that are working for you in your office setting, and you don't want to put them in harm's way either. Office preparation, practice social distancing, patient HMPs and so forth, mask, gloves at a minimum when you're in the exam room. If you examine the patient, make sure you have gloves on. The surfaces need to be sanitized, and you want to have a gown on if there is a high index of suspicion. Now, the one that kind of gets a little funny here is the procedure room. So if you are doing procedures or you start doing procedures that are either emergent or urgent for patients, that 6 feet of social distancing is null and void here. I don't know anyone who can do an epidural 6 feet away from somebody. So you may need to consider gowning as if you're doing a surgical procedure or a much more sterile environment kind of procedure with gown, gloves, cap, as well as a mask. So that's food for thought as we kind of move into this new normal for us. Next slide. So a lot of this is really from the CDC website, so cdc.gov. ACIP also has a lot of information that's available. They've been sending emails as well, talking about how to start getting into providing care to patients and procedural care, and that's available on acip.org. Webinars like this will provide it, but I think the art that's available or the handouts that you can download from both sources can be very powerful for what you're trying to accomplish as far as educating your staff and your office workers.
So Steve, I have a couple questions for you.
Sure.
The first question is, you talk about exam, but I've been examining people by telehealth for 6 weeks now. Why do I need to examine someone once they come to my office?
Dr. Deere, it's amazing that you asked me that question, because I find telehealth to be so frustrating trying to do a physical exam. And it's funny, in the past, I've said, I don't really put my hands too much on patients, even when they're in my presence. But it's amazing what you observe from just seeing the patient sitting in the chair, standing up, ambulating, and just even pointing to their body. Because when I'm on telehealth and you tell me my hip hurts, 9 out of 10 times you're really pointing to your SI joint or to the sciatic region or gluteal region. So there is a lot to be said about the actual evaluation and seeing with your own eyes what the patient is doing and how their postures and their body language changes when they're discussing their issues. That being said, the physical exam, listen, 80% of what we do is done by the history, right? And so we all learned that 80% of everything, our diagnosis is history. But there are subsets of where I can't differentiate the difference between an L5-S1 radic, an L5-S1 facet pain, or an SI joint without actually getting and churning, the hip or the back to figure out where the generator is from. So I don't think telehealth is a very good replacement for those conditions. But at this point, we have to do with, make do with what we can do right now.
So one second question follow up, and then we have to move forward. But so a lot of doctors, Dr. Abihan in Spain, Dr. Barani in Leeds, Dr. Lynch, Dr. Bremer in America, Dr. Gracinko in New York City have been pulled to the ICU. Yeah. Or the ER, right? So now they want to come back to their practice and do pain. What should we do? Is it 14 days of being alone and secluded? Is it a rapid test for 5 days? What's the protocol to let someone come back to our practice around our nurses who we've been protecting like crazy for the past 6 weeks?
So that's a really challenging question right now, because let's address the testing part of it, because right now there isn't, not everybody can get a test. Tomorrow I'm going to have my antibody test, just to make sure, and I've been waiting 2 weeks for that. So that's one option: is the testing available? And if the testing is available, what is the time differential in you being positive or being exposed and then demonstrating symptoms? The CDC put out 14 days initially, and then all of a sudden for healthcare providers, it was like, well, if you're asymptomatic for 7 days and you potentially had an exposure, it's okay, you can go back to work. And I don't know what the motivation for that was. Was there a shortage, or is it truly, they're asymptomatic and you're not going to present? I think the 7 days is okay. The 14 days is ideal for self-quarantine, but certainly, we as physicians have an obligation to do no harm, right? Do no harm to others. So if we're going to present with symptoms, I think we would be the first people to say, listen, I'm not feeling good. I have a fever of 101. I was working in the ICU 2 weeks ago. I should probably, or 5 days ago, let's say, I should probably pull myself out until. But I think the 7 days is good enough. I don't like that answer, but the 14 days would be ideal.
Okay, so I'm going with 14 days. So thank you for that answer. I appreciate it. And I think that's the end of panel number 1. So great job, all of you. We're very impressed. And I had 2 kids come back from spring break, and I made them stay in their rooms for 14 days. So I'm a 14-day type of guy, personally. But I think that's the safer thing. Dr. Dewan, would you like me to ask the legal question before we go to panel number 2?
Yeah, I think Jennifer is standby for a legal expertise. Jennifer, can you turn on your camera, please?
Jennifer's going to join us now. So there's a legal question that came about that I think is a great question. And the legal question is this, and Jennifer, I'll ask you this question, and then I'll certainly wait on your answer. The Payroll Protection Act, PPP loan, really sounded great to all of us. But in West Virginia, I know my banks well. I was able to get that loan, thankfully, and it really helped our practice. But in big cities, a lot of people can't get the loan because there's bigger corporations ahead of them. And is there something there that they could do from a legal standpoint? It's a question when the banks are discriminating against them for being a smaller company. And if that's true, what's the steps they can take? So I'll give Jennifer that question, then we'll go to panel number 2.
Jennifer, are you there?
It appears Jennifer has hung up her line. Let's hold that question and we will loop back with her afterwards.
Okay.
All right. So well, Dr. Dewan, take back over for panel 2, Dr. Dewan. That'll be keep that question in your mind, though. That's a good question because I've heard a lot about that recently, Dr. Dewan. I've heard people say they're having trouble getting that loan. And that's a real problem if you're trying to pay your staff. So great question, Dr. Dewan, panel 2.
We have almost ran out of time, but I have one more question for you guys, you and Scott. How would you recommend your patients about testing? Who should be tested and who should not be tested?
Oh, it's a great question. A lot of that has to do with the availability of the test itself in your community. Some advocate testing everyone once it's widely available, but I think certainly if you've had a patient that has had a family member or they've been in a nursing facility and have had some kind of an exposure, they are at risk of developing symptoms. If the test is available, you would like to utilize that test. The ACIP has put together a COVID task force. Thank you, Dr. Dewan and Dr. Garuba, both on that task force, trying to help guide us in when those patients should be tested and who's appropriate for a procedure. So I think if you did have a patient that had borderline health status, had some risk factors for potentially having a poor outcome, then a serology test would help you make a decision on whether it was safe to proceed or not. So those sort of tiebreakers might be the ideal patients to test, while the more healthy, straightforward patients may be less of an issue. So I would say if there is a shortage of testing, save them for your tiebreakers. If there's plenty of tests, anyone undergoing any kind of elective procedure should be tested.
Yeah, just one question.
Dr. Aiden?
Yeah, I would agree with that. I think if you have risk factors, whether you have a risk of exposure or you're in an environment where you could have an exposure more than the general population, I think it's a good idea to get testing. If you have a patient coming in for a procedure, whether you do, the rapid test that they have that's working, or if you do serology testing, the biggest thing is if we do the testing, what do we do with that information? And that's what we really need to figure out. And I don't know if we have that answer yet. So for the most part, I would agree with what Scott said.
Very nice. Thank you very much, everybody.
Yeah, just one quick question. Do you guys differentiate between protection for cervical, head and neck procedures versus lumbosacral spine procedures, let's say sphenopalatine or stellate versus LESI, in terms of our protection, patient protection?
I mean, certainly for anyone who is supine for a procedure, there is going to be a much higher risk that as you're getting closer, you may potentially get an exposure to them. Whenever I'm doing a procedure for the patient, even though it's a little cumbersome, they have a mask on. So if they are in the face-up position, they should absolutely have a mask on. In the prone position, most of the time the mask kind of like muffles them, and they kind of feel like they're suffocating in the positioner. So sometimes I'll tell them, listen, just take it off. It's okay if you're having a hard time, breathing or being comfortable. But in the supine position, absolutely. You should probably even put on a set of goggles or a shield, because God forbid, if you get close to, say, the trachea and the patient wants to cough, they're going to spew out all into that environment. So you should be enclosed as much as you can in that case.
Thank you.
Thank you very much. We are actually out of time for this panel, and I thank you, Scott. I thank you, Dr. Eden. I thank Amol and Shalini. They actually left for another panel, but it was wonderful. So I thank you for your time. Please stand by, because at the end of the another panel, we will have time for any questions that we can direct for you towards you. And now we will move on to, before we move on to, is Jennifer available? Hi, Jennifer. All right, so we will keep the question for Jennifer at the end of the session. Let's move on to panel number 2. The panel number 2 is focused on telemedicine and how to go back to a new normal and adjust our clinical practice to succeed after COVID-19. It's my pleasure to introduce our first speaker, Andrew Kaufman. Andy is a very well-known physician. He has been quite active, especially in our New York, New Jersey Pain Symposium. He's been director for Fellows and Residents Workshop, which is one of the very successful workshop we have. Last year we had standing room only. So, and Andy has contributed tremendously in a literature. So we are very honored to have him with us today. Please take over, Andy.
All right, thank you so much, Duan. Thanks everyone for taking time with the multitude of webinars to pick ours. I'd like to think it's a very good one. In terms of one of the questions that I was asked to answer was about opioid prescribing during this pandemic, and what are the implications with that, as well as potential of the drug testing that we're required to do and that we want to do. If you all remember your opioid laws, and unfortunately I've become very involved with stuff like this, the DEA requires a face-to-face visit to actually prescribe anything, and that's in their mandate. However, because of what happened on January 31st, actually, HHS Secretary Azar did declare a public health emergency. When that happened, they ended up talking to DEA and other regulatory societies, and what the DEA missive came out was shortly thereafter, about 3 weeks thereafter, was stating that the practitioners could continue to prescribe opioids. However, they must do a true visit like you're seeing me right now. You need to do a true televisit. It can't be a phone visit. It has to be a face-to-face visit, which would account for a true visit. Now, we all know that CMS has allowed these televisits to be billed E&M codes, which would be regular office visits, 99212, 3, 4, etc. So this would now account for the actual visits. So we continue to make DEA regulations. Now, we're not talking about our individual state regulations. Like in the state of New Jersey, they have a missive that they really want patients to be seen on a quarterly basis, so we can still have your patients come in with that. Every state's going to be different in terms of what their return is. Now, if you have been doing a monthly visit with a patient, you can continue to do that, but it must be face-to-face. One of the problems that we have is the actual prescribing of the medication, in that, believe it or not, at Rutgers, New Jersey Medical School, we don't have the capability of doing controlled substances by e-script because there are technical difficulties. I think hopefully a lot of people are able to do that. So I know Chris is smiling because it's just crazy that we have that. But what we're doing for the first time ever is actually mailing paper prescriptions, because I have to patients, which is accepted also at this point, or family members can come and pick them up because they don't want to have someone be exposed. They'll just come, literally pick them up and leave. But you do have to document that you did that actual face-to-face visit as part of your telemedicine visit, which I'm sure we're all doing, because we need to document that so we can bill our proper codes. Look at the next slide, please. So once again, you need to follow the absolute DEA regulations, and that includes legitimate medical purpose by a practitioner acting in the usual course of his or her professional practice. I've found that, unfortunately, due to the crisis, like Tim said, we have not been able to do a lot of things, more advanced things that we'd like to do. We are doing emergency epidural injections on patients with profound disc herniations or severe stenosis, but we've had to place some patients on opioids because we have no choice. And obviously, it's something we're trying to avoid long term, but this is a short-term gap. But as long as you're acting with accordance with all the federal and also your local state laws, you're going to be safe. I don't want you to worry about that. But this is where documentation is always key, but especially in this time, document, document, document. Please make sure you're doing that ad nauseum. You can't do too little, or you can't do too much, I should say. You can definitely do too little. Next slide, please. Thank you. Now, in terms of drug testing, and I just wanted to put this up to remind people where things can be from last dose. I mean, obviously, hair is great. You know, people getting poison from their spouse, and maybe that's going to happen with everyone being stuck together. They can look at hair. We can look at sweat. But what do we usually do? We look at urine, right? We look at urine. Sometimes saliva. Patients can pee for us. But if you can see, urine really is accurate for 4 days, approximately from last dose. Saliva is a little bit less at 2, and blood's even a little less than that. So this is where we stand in the testing paradigm. Obviously, we're not going to be doing urine tests on patients, right? They're not coming into the office. They're not, you know, getting in and getting the urine test, because that's a requirement for our practice as well. However, there are some ways around this. Next slide, please. I called in preparation for this. I reached out to several major testing companies, and I don't endorse any one. I mean, I tend to use one myself, but I reached out to several to find out what are they doing, what do they have available, and every major company that I called will help with this. What they've told me almost universally was that they will actually mail kits to the patient's home. And then there's 2 ways to go about this. They can then rip the kit open when you tell them to, so you can physically see them opening the sealed kit. And then they could take out the swab and then do it in their mouth as you would instruct them, rolling it in for the saliva, take it out, put it back into the vial, breaking it, sealing it, and then putting it back into the sealed kit. That's one way about that. Now, some of the companies will even, with the patient's permission, send a representative to the home to do the test while you are on the audio visual with them, so you can see the actual test. I'm not sure if patients are going to want someone to come into their home, but that's something that several of these companies are offering. So that's something that could be done. This is a stopgap measure, obviously. I mean, if they're putting it in and sealing it and then putting it into the sealed envelope to be mailed out, could they adulterate it? I guess they could. However, this is a way, if you really feel that you need to drug test someone right now in this time, that's a way that we could get through this. It seems like a fairly practical situation. I haven't done it yet. That being said, I'm not initiating any new patients on an opioid. I've reinstituted certain patients that I've had in the past. And what I've done is I've faxed them or emailed them their opioid agreements and opioid consents to re-sign. And I get them back. So it's always a consent form that talks about risk and benefits, just like you would with any procedure. And we have a separate opioid agreement that talks about behavioral expectations that they allow us to drug test, et cetera. So I make sure that you send those to those patients also, whether by email or fax or physically mailing it. Some of my older patients don't really get the whole, email scanning thing. And I need to have those back on file before that we would even prescribe. So I think that would be a proper way of doing that. In terms of continuation with telehealth with this is still in progress. The original CMS ruling was till the end of June. I'm sure that's going to be extended so we can continue to work this way because patients are fearful for coming in. So thank you, Andrew.
So Andy, let me ask you a couple of questions here very briefly before we go on to Dr. Rubin next. But the question really is this: I spent myself, people like Stan Golovac, we spent the last decade yourself trying to get away from this opioid crisis we've been in, right? So it's been a horrible crisis. I think we're winning the battle for prescription opioids. What worries me is, and AAPM came out with a recent policy that Steve Cohen led, and overall it was very nice, but there was one section that said, consider opioids in these patients who can't get out for procedures. What's our worry? Are we going to restart a new opioid crisis here? What's your thoughts?
It's funny that you say that because we at the New Jersey state side of interventional pain physicians just had we have a weekly board phone call on Mondays, and we were just discussing this, and we're coming out with a white paper for the state of New Jersey for Governor Murphy addressing just that. And I know Sean's, I see Sean here, he was on the call, and Dr. Waska was. We're concerned that we don't want to refuel a second phase of an opioid epidemic because we're being limited in the ability to take care of patients with basics. I mean, forgetting even the more advanced things, the stimulators and whatnot, but even the basics that we're doing, the epidurals, radio frequencies, or even workups for that. So that's something that we're very, very concerned with. Look, I wrote my first Vicodin prescription in 4.5 years the other day for a patient that desperately needs a laminectomy that's being delayed because it's not, essential or emergent. And so I'm very, very concerned about this. And we don't want to be doing this, but this is more for your ongoing patients and for the few, maybe in the last 6 weeks, I've put 5% of my patients reinstituting an opioid at this point.
One more quick question. Nurse practitioners are important in my practice. Where is the role of the nurse practitioner of helping you keep these patients on track with their prescribing?
Well, if I had my nurse practitioner who wasn't floated to the ER, so right now I don't even have one, but the CMS is allowing nurse practitioners as well as PAs to also initiate the televisit that we're doing as long as it's documented, and then you can still issue the necessary prescription. So they've relaxed that rule because of the crisis.
No, thank you. That's information I wanted to get out there. So great answer. Thank you very much, Andy. As always, a wonderful job. Our next speaker, Ed Rubin, is certainly a leader in the New Jersey area, director of chronic pain management at NYU, Winthrop, and Ed's been a great leader in both the outpatient surgical center as well as in pain overall. So Ed, the podium's yours, sir.
Thank you. So, we've looked at this from a number of different angles. Now we got to put ourselves in our staff's shoes and say, how are these people who may not all be RNs and PAs and NPs, some of them are medical assistants who signed up to work in an office and not necessarily in a setting where they're going to be exposed to, some terrible viral illness. The premise of community spread, where we're at now, at least in the state of New York, you could get this going out to the supermarket. Like, because you're in a healthcare setting doesn't mean necessarily that you're putting yourself at any more risk if you take the right strategies than you would if you were just going out shopping or doing the daily life activities because of the prevalence we have in our area. But just like we're risk stratifying our patients, I think it's important that when you look at your staff and who you're going to bring back and how, you really should risk stratify your staff as well. Do you have employees that are at high risk? If they contract COVID, are they likely to get very sick? Without delving too much into people's personal medical histories, I think you need to give your staff that, space to tell you, hey, if you have anything I need to know that you feel puts you at high risk, please tell me, let's talk about that and allocate you correctly. I still feel there's a lot of work that could be done from home. Am I getting 100% productivity out of my people working at home? And for the last 7 weeks, I've had 100% of my staff working from home. I've been the only one physically in the office and basically here by myself doing telemed. So, these people are now going to be asked to come back to a certain extent. Maybe your high risk ones need to stay at home. Medium risk people can do more back office stuff, and your younger, healthier, less likely to have complication type people are going to be your, front office type people. And then identify the minimum number of people that you need to physically be in the office and try and keep everyone else out for now. It's going to make it easier for you for social distancing and spacing them out. And from the staff perspective, the more we can make the contact, the physical contact between the staff and the office decrease, the better. So like your front desk people aren't normally supposed to be physically examining or in contact usually, but they're going to get past papers and they're going to get past clipboards, and you got to think about, these types of things. In my office, we just yesterday installed plexiglass basically all around the check-in. It used to be an open area, open to the waiting room, and I just put, at reasonable expense, a complete wraparound plexiglass. There's some room in there to pass papers through in various spots, but there are physical barriers that we can put up. Some of the things that have been hit on, I may gloss over here, just to not be repetitive, but we talked about calling people ahead of time, screening these patients, trying to make as much virtual as possible. I know a lot of people in our profession use scribes. And again, now you're going to have somebody who's, a lower level type employee, not necessarily even, an RN or an NP or PA, in the room with you. Maybe you want to make that position virtual. If that person knows you well enough to just be on an iPad and, FaceTiming in, maybe they can sit in another room and type just as effectively as if they were in the room with you typing. So those are some things we could do. Staff PPE, you're going to have to look at what position they're in and decide, how much PPE do they need. If you have somebody outside greeting patients and screening them at the front door, those people might need max protection, gowns, hats, face masks, versus my people behind plexiglass, maybe mask and gloves is sufficient. So you're going to have to sort of depend on what they're doing and how much exposure they have to figure out how much PPE you need to allocate. A lot of exam rooms are set up where there's one computer, and different people are jumping on and off of those devices. We really need to look at limiting, cross-contamination and shared devices. If you take nothing else away from this talk, here's the one thing I would remember. Document that you trained your staff on all of this and that you provided adequate PPE and have them sign off on it. This is not some, you being off the hook if they get sick, because you're not, but this is just doing the right thing. Obviously you want to train them, you want to give them PPE, but document it, have them sign off that they were educated, whether it's watching a video. I physically showed them. How does my medical assistant know how to, take off a N95 mask without contaminating themselves? So, document that you did this for your employees, have them sign off on it, that they've been provided with adequate training and adequate equipment, and tell them to speak up if they feel otherwise. That'll save your butt potentially in the long run if somebody turns around, 6 months from now and says, I didn't have what I need, nobody trained me, I got left to the wolves. We went over UTOC, so I'm going to stop doing urine and switch to oral myself. So now this came up a little bit before, like what if your staff, is exposed or gets sick? It doesn't necessarily have to be in the office, but how do we deal with staff who've had it or been exposed? Should you get them tested? Well, if they've been with someone who has it or experiencing symptoms or been in some high-risk situations, then you should probably recommend getting tested if you can access it. What if they've had COVID? What if they've had a positive test? And again, we touched on this. This is from New York State's Department of Health. basically you have to isolate for 7 days and be fever-free for 72 hours. There's nothing mentioned in New York State's guidelines that you need a negative test to come back to work. A little shocking to me, but that was the recommendation, was 7 days and 72 hours. It says to wear a mask for 14 days. I'm pretty sure that was put out before we decided everybody should wear a mask all the time. And the last point was that those people should be assigned to lower risk activities when they first return. And that's it for me.
Great content, Ed. Very useful to private practices and to academic centers in general. My question to you is, you bring up a very interesting point in terms of risk profiling of your staff. Is there a resource you can recommend that our colleagues can tap into to determine how to go about doing that in a way that's acceptable?
It's tricky because it's not like a patient where you have all access to their medical history, right? It's implied that when a patient comes to see you, you have the right to know, that they've had leukemia and that they have a stent in their heart. You don't know that with your staff. So it's a delicate, thing to bring up, but I don't have a specific resource. I would say it would be the same way you would risk stratify patients for bringing them in for an intervention, in terms of saying who's high risk, medium risk, low risk. Not a lot of us have elderly staff members, so that's not a big component of it. But you have to delicately give them the opportunity to speak up. And I had this talk today with my staff. I said, look, I'm not trying to pry into anyone's medical history, but if you feel like you have a condition that precludes you from working, let's talk about it, even if it's in general. But we're not going to know everything there is to know like we will with our patients, so it'll be a little trickier.
Any thoughts about getting a third party involved to risk stratify the staff?
I think you just got to do everything you can to provide them with the right equipment. Like I said in the very beginning, at least in New York, you could get this anywhere. You go Dunkin' Donuts and get COVID at this point. So it's not like, being in the office is some super high risk thing compared to being out and about. So I think you just have to provide as much as you can. I think a third party might just add more layers of complexity to it. I mean, I use Jen Kirschenbaum, and I've been talking with her, and maybe we'll put together some documentation for the staff. But if you're asking me about a third party, I would say, consult with your healthcare attorney just in terms of how you want to document all this.
Okay. Thank you. Very valuable information. Next, I'd like to introduce Dr. Sean Lee from National Spine and Pain Center, who's a good friend of mine who I've invited to NYU to give us wonderful talks on neuromodulation. He's on the ethics committee at ACIP. He's on the education committee and young neuromodulators committee at the International Neuromodulation Committee. And he's the secretary of New Jersey SIP. And he's going to present to us his thoughts on how to prepare procedures with and without steroids in the first phase of return. Dr. Lee, it's yours.
Thank you, Dr. Garibo, and thank you, Dr. Dewan, and everyone for inviting me. It's a very humbling experience to share our experiences and learn all together. So as all the states are trying to come out from hibernation and resurge from the COVID pandemic, we want to prepare ourselves on how to do that safely. And I've learned quite a lot from the first session in terms of patient safety and staff safety. So I'm going to try to not redo some of the things that were already said, but essentially we want to come out in a cadence that's safe for our patients, safe for our staff, and utilize the federal and state guidelines to follow, so that we are creating a process, a protocol. So we were very fortunate. Our CMO, Dr. Stats, as you all know, along with our internal COVID team, developed patient safety guidelines and staff safety guidelines before really all of this hit. And we wanted to ensure that we're making ourselves available to our patients, but at the same time, keeping our patients safe and not spreading the disease, and making sure that our staff remain safe and they don't get sick. So obviously, various states are going through different state mandates, especially in New Jersey and New York, some of the hot spots. We are still under an executive order not to perform any elective procedures, and only do urgent and emergent cases as we see fit. But also you want to follow your local and regional guidelines in terms of how available certain things like ventilators or PPEs, because we don't want to use up valuable equipment. But one of the controversies is obviously the use of steroids in injections. Much of what we do involve injectable steroids, whether it's in the joint or the epidural space. So I'm going to try to bring up some information regarding that and offer some guidance. So next slide. So this part we already mentioned earlier, and some of the graphics didn't come through, but essentially you want to risk stratify. So not just in urgency, but you want to risk stratify your patients. So in terms of urgency, for our area, we're still concentrating on mostly urgent and emergent cases. We plan on, as the executive order expires mid-May, to slowly start attending to our semi-urgent and elective cases. We want to do it in a fashion that's safe for everyone. So the information and guidance has been put out by various societies, including ASRA, as well as our parent society, ACIP. Next slide. So in terms of injectable steroids, we've heard a lot of noise regarding things like non-steroidals and so forth. And at this point, the World Health Organization has not said one way or the other if NSAIDs are actually detrimental or negative. However, we use a lot of injectable glucocorticoids as part of our treatment therapies for our patients. So we all know that steroids may increase the effects of adrenal insufficiency and alter our immune system. So we know, but we don't know how much. And in actuality, there's no data that exists in terms of the effects of steroids that are injected in the epidural space. All of the data comes from indirectly from systemic administration. So there's some information that was provided by CIS as well as ASRA that there are some indication that if we administer steroids such as prednisone at a dose higher than 40 milligrams, it inhibits phagocytic activity of cells, which are part of the immune system. In rheumatoid arthritis patients, giving a large dose like a gram of methylprednisolone can cause leukopenia within 2 hours, but resolve over 24 hours. So some patients may ask us, well, how does this immune depression, how long is this going to expect it to happen? We only have indirect data, but this is what we have available. We know that the use of dexamethasone and betamethasone may be less impactful on the immune system than some of the other steroids that we choose to use. And you always want to obviously adjust and tailor it to the individual patient. For some patients with higher risk, you may want to avoid steroids altogether or utilize a lower dose. And those are the links I've provided from both the ASRA as well as from the Spine Interventional Society. This was just put out 2 days ago by ACIP, and I thought it was a nice illustration of how we can risk stratify our patients based on need. Obviously, as we start to do elective procedures, we're going to screen out the patients who are active in terms of disease, but those ones that are not showing symptoms either by screening process or if available by testing, we can proceed on to slowly and safely proceeding to the elective procedures. But you always want to risk stratify in terms of patients who are low risk, for example, someone who's healthy otherwise versus someone who's high risk coming from a nursing home. So this is information that was put out and that's available on the ACIP website. For that, I'm going to end and offer any questions.
Sean, thank you so much. This is a wonderful presentation. I have just one question for you. Does it make any difference whether you use the longer-acting sustained release steroid versus the short-acting steroid?
Well, in this slide, I mentioned that dexamethasone has been noted as something that is preferred over some of the longer-acting steroids, but there is no definitive data. I think steroids as a general class of medications is something that we have to use with discipline and with caution, especially with a viral pandemic that's still going on.
Excellent. Thank you so much, Sean. And this was really very, very helpful. I truly appreciate your time. Please stand by because we will have some questions at the end of the panel. And we're going to move on to next speaker. Our next speaker is Dipan Patel. He's our young and enthusiastic blood that is bringing a lot of energy in our interventional pain community. Dr. Deer has been his mentor, and he's really, helping him a lot. Dr. Patel is expert in neuromodulation. He teaches in a local and nationally, and he's been one of the experts into technology, IT, and telemedicine. So we had a lot of discussion on telemedicine. Deepan, take on and give us some more clarity on issues.
Thank you, Dr. Wan, for the kind intro. So I'm just going to jump right in and basically perform like an overview of exactly what we're dealing with and what we're going to deal with going into the future. The way that I look at it is similar to toothpaste. I think that the toothpaste is not going back into the tube when it comes to telemedicine. And one of the things that we need to ensure is that a lot of the regulatory actions that were taken during this active pandemic, especially mirrored across the country, should be thoughtfully extended, well after the emergency is over and after we emerge. One of the issues that really came up is that some of the old policies that were in existence prior to the onset of the pandemic was that the restraints were, pretty bush league and strangling in terms of patient access to care. So, relaxing some of the requirements, which include that the patient must physically, be in a certain telehealth approved location when their appointment is taking place. It's been relaxed, and now patients are able to receive care within this comfort of their own home. Also expanding the list of people who can provide these telehealth services, beyond just physicians, right? When we prescribe physical therapy or any other type of service, whether it's psychological services for neuromodulation, I think that's going to be imperative for us. But ultimately what's going to happen is, we as a society, we have a tremendous amount of leadership that's working really hard outside of their private practices and outside of their academic careers, where we really need to kind of unite and make sure that the impetus, now that telehealth is getting its day in the sun needs to be supported by us as societies, regardless of which society that we're currently active for and which one we have a title for. Ultimately, our society support will be imperative in terms of trying to support these telemedicine endeavors as we go into the future. And I kind of just emphasize that on the next slide as well, because right now we're in the kind of state where we have this golden opportunity where we need to make sure that as we emerge, we're also ensuring fair reimbursement for some of these telehealth services. Because ultimately some of these, the laxity in some of the legislation is going to be lifted at some point as we emerge, and then we're going to be depending on some of these telehealth services because we're going to become accustomed to building it into our practice and using it to improve our efficiency and our revenue. And to have that, abruptly yanked from our practice would cause somewhat of a disruption, later phases as we emerge. And on the next slide, I just kind of reiterate exactly what we've been hammering over the last month or so with a lot of these educational webinars is, how do we get this efficiency bar from bad to poor and keep it in the excellent part of the phase where we have the green light and we're really, improving on our revenue streams in our practices. I think we all know what the benefits are where telemedicine appointments, they significantly help reduce the no-shows, right? Typically, and especially in the field of interventional pain, we get a lot of appointments that are made virtually or online from our booking systems, but ultimately, the no-shows that happen or the late cancellations because people are working or they're, something comes up abruptly with their family, you're solving that problem where you can still get them access to care, and it's also it improves your efficiency because over the span of a year, if you look at your year to year and the amount of the scheduling impact has on your revenue, it can lead to the amounts of thousands of dollars from having those open spots on your schedule. Ultimately, in terms of how it's going to actually optimize your practice efficiency and patient flow, less no-shows and late appointments means a more efficient practice where you're offering pretty much on-demand telehealth appointments, can help you fill in some of the gaps in your previously existing schedule, whether they be from same-day appointments made or urgent patients that need to be seen acutely. And also, it can also have, the patients can also check in online or through your website, or fill out forms prior to even being seen, which also reduces front office staff time in getting them ready and prepped to see you, because typically most patients, they don't walk right in and see the physician. There's multiple barriers and steps that they have to go through, whether it's filling out the paperwork, verifying the insurance, seeing the MA for 30 minutes, and then finally they get to see the physician. So I think that in terms of the office efficiency and the actual the decrease in the burden on the infrastructure, you're actually improving that aspect. Also helps you recapture some billable time, right? You have optimized billable hours this way. So that's one of the most important things, where you can kind of, really take the time to expand your availability, right? So one of the things that I did in terms of my own practice is I tried to offer appointments, early for those that may, have that time early in the morning or right after their third shift work hours, or late in the evening. And also Saturdays, right? So a lot of people have, disagree with working on Saturdays, and they say, you're young, why are you working? But for us, I think that patient access and availability, we have a lot of patients that work Monday through Friday, and they don't have the luxury to take off time from work, because time is money for them, and that economic impact that it has is something that you cannot compromise. So the other thing that, it also helps you develop some sort of a competitive advantage, an edge that helps you attract new patients. So as we emerge and the consumer confidence returns, and patients start to build confidence in terms of coming back and getting care and undergoing elective cases, you're going to be able to attract that subset of the population that you couldn't before. And I think that, if you look at the satisfaction studies that they have with telemedicine, it's pretty universal in terms of having a positive impact on patients seeking care. So, that's something that we need to keep in mind, and also amend if we're not, doing these things currently. Also, some of the things that we do ourselves, either before office hours, official office hours, or after hours, we can also get paid for it, right? So a lot of these phone calls and, virtual check-ins and e-visit opportunities that we have, we need to capture these and add it to our billables. And ultimately, the biggest thing is just marketing the access. A lot of people don't know that this is available and widely spread, and I think that going forward, we all need to do our part in terms of making sure that that's done.
So Deepan, that's a great summary. I'm going to ask you 3 rapid fire questions. We have about 25 minutes left for the overall question and answer. Question number 1, I've often said young fellows want to live in New York City, New Jersey, LA, San Francisco, Seattle, and the rural healthcare in America is going to suffer because of lack of specialists. Do you think that telehealth can solve that problem? And if so, how big a problem is the lack of broadband in those rural areas?
Yeah, it's in a lot of the articles that I was reading, I think that's a lot of what, and we see these astounding numbers that like hundreds of millions of dollars or $2 billion being invested into some of these legislations that's going to support the expansion of telehealth services. I think that this is only going to help. It's not going to be immediate in terms of the infrastructure being put into place, but the government and Congress has committed themselves in terms of the financial aspect to make these things available, which I think ultimately will improve the practices in our rural areas, and may make them a little bit more attractive for new graduates to actually, I would say, take on that opportunity, not just to entertain, but actually to commit to one of those opportunities, because that's a significant amount of concern for a lot of people. Like, how am I going to be able to provide service for all these people? Well, that all of these building blocks and foundations are being put into place now, and this is the time to kind of capture that opportunity in case of the event where you have these new fellows that may not be being able to continue with their job search in the ideal demographics and where they were ultimately looking.
And just a quick follow-up, and that is, how do we examine people on telehealth and then get approval? I just got approval for DRG today. It took a really convincing peer-to-peer discussion on the phone. So how do we examine people on telehealth, and how does that lead to approval procedures?
Exactly. Yeah. So one of the exams is it's limiting, right? And that's one of the problems that we have, is that you can also have technical difficulties with, observing the right diagnosis and approaching the right diagnosis, instructed exams are difficult. I think from a technological aspect, I think that there's a lot of improvements that need to be put into place before we can accurately examine these patients and indicate them for the right procedure. I think that, you know, one of the options for that is that when you have an initial consultation, ultimately, you know, if there is any type of unclarity, you need to keep in mind that telehealth doesn't eliminate, right? It enhances the patient-physician relationship. So although, you know, a large, you know, our whole field is built off of physical examination, you know, combining it with the history, making an assessment, and then executing your plan. So I think that, you know, it doesn't eliminate, but it will supplement.
I have very quick
Very good.
question for Andy and Dipan, one of you. There are many questions are being asked is about audio and video. So can you clarify the cord and whether do you think that the audio only is okay or you need both? Because there is a lot of confusion because there is changes in CMS. Andy, you go first.
Yeah, I was an early adopter with this with the medical school, and I've been involved with some of this. To do the regular code of 99, 212, 213, 214, your regular visit codes, it must be audio-visual. I saw some questions coming up, and you must document that in your note that it was audio-visual, that you were in your office, the patient was at home. You also must put time on the visit. That's essential. You know, we're using Doximity. That's what the medical school bought, and it's great because there's a timer with it. I'll literally tell the patient this visit took place over 17 minutes, and I will document that in the note. I tell the patient that the exact time also. If it's audio only, and we have a lot of patients, especially in the Newark area where I'm practicing, that don't have computers like we have or smartphones. So we do it over the phone, and you must do the 99441, 442, or 443, which are pure audio visits. They pay at a lower rate. It used to be there was a G code involved, but they've eliminated that. So those are the two sets of codes that you must use. And then you also must put that you did audio only. So it is at a lower rate, but it's higher than the G code used to be. And I think I'm right with that, Dipan, right? That the G code was even lower. It was like $10 because it was just a quick phone check-in. That's how it was billed as. But they've changed the rules for that. There was a question about New Jersey PIP. I did see the ruling that came out that they had to pay for that. However, as far as I know, it's audio visual, not just audio. And if anyone from New Jersey, I know Scott may have a better idea about that than I do, but to do those codes, what they told the insurance carriers is that they must follow the CMS codes that audio visual counts as a regular visit no matter what it is by time.
I have a question for Dipan and Andy. It's a combined question where telemedicine is probably here to stay. It's not going back into the toothpaste tube, but there's probably going to be a composite of in-person visits and telemedicine visits. And as it applies to chronic opioid therapy, what's your current guidance as far as how we can alternate those two types of visits? At what point do we make the patient come in? What are some of your sort of hard thresholds to pretty much request an in-person visit for chronic opioid therapy?
Yeah, exactly. So I had an interesting situation where so far, you know, in the last 6 weeks where we've been dealing with the outbreak of COVID-19, we have, I can't even count on one hand how many new patients we've started on opioid therapy. However, a lot of patients have been displaced, and those with high comorbidities, such as, you know, a couple days ago, I had a patient who had, you know, end-stage renal disease and was referred over from the dialysis center. Her pain management provider had not, you know, had implemented telehealth at all. So she really had nowhere to go. And in this situation, you know, using the New Jersey prescription monitoring program, using medical records obtained from the actual dialysis center and my own clinical judgment, you know, I didn't withhold care in making someone who was, you know, at the end stage or palliative, you know, more miserable in terms of trying to throw up more barriers and trying to provide care. So in these situations, I didn't require the patient to come in. However, there are certain situations, like when you're dealing with an acute radiculitis and things like that, where some people may be comfortable, some people may not be, and it may be kind of like a judgment call based on how quickly they can get the new MRI, how quickly we can get them in for an epidural, how quickly, you know, we may need to do electrodiagnostics in a situation like that. And you know, that's kind of something that is based off of, you know, the individuality of the provider giving the care. So for me, I would request that patient to come in and actually do physical exam on them. So I don't think it would replace it in that situation, but there are situations where I think that we can use our best clinical judgment and not having to make every patient come in every single time.
Chris, I would agree with that, saying, especially a new patient, I want to see them. I want to know what's going on. We're still checking everything. The example I gave earlier was on an existing patient that I had known for many years, who I then decided to put on something. Different story because they're with you. Going forward, I'm hoping again that we can continue this. So certain of my patients, I do have probably less than 10% of my practice on chronic opioids, a lot of historical patients. I would like to see almost every other visit. I still subscribe by the New Jersey state rules where I see them on a quarterly basis, but I could see doing every other visit telemedicine, right? What they don't need to really come in, and I could do an every other visit telemedicine, because then on the other visits, I could get my random urine screens. They don't know when I'm going to do that screen, right? That's why it's random, but that I could still get that urine screen versus, because it is much better than the oral swabs. There's still problems with the oral swabs versus the urine screens.
Okay, I want to ask a question, Sean. I want to ask a question to Sean Lee, actually. So, Sean, if I get a patient coming to see me who has COPD, diabetes, and has a lot of comorbidity, so if they got COVID, they'd be a huge risk, but now they have a herniation in their cervical spine, and they have severe pain in their arm. Which is the lower risk, an epidural with Decadron or an opioid? How do you make those decisions? How do you triage that?
That's a certainly tough question. I think one of the
I had this patient 2 days ago. That's why I'm asking you. 2 days ago, I had this exact situation.
As Andy was saying, we were talking about this just on Monday. We're coming from still recovering from an opiate epidemic, and we're in the middle of a COVID pandemic. So we have the responsibility to not perpetuate this. But I think, as pain physicians, we're the best trained to utilize opioids when you see fit. So in that particular case, if it were me, and right now we're still under the mandate of not doing any elective cases, I would still try using a responsible amount of opioids along with non-opioids to try to treat that patient as best as I can before they get into a situation where the next step is they're risking going to the ER for further treatment. And that's where we want to keep them away from. So that's when we start implementing or think about doing that epidural steroid injection. Considering that someone has severe comorbidities, I may not even want to do that case in the office because they may need the additional attention and monitoring and so forth. And so our local ambulatory surgery centers have allocated days where we can do urgent cases as long as we abide by the state mandate. I have to justify why that patient would be considered an urgent procedure.
Great answer.
I think we had some question for Jennifer, but she is having audio-visual and some issues with the problem. Jennifer, can you hear us?
Can you hear me, Dr. Dewan?
Excellent. Tim,
Hello?
you had a question for Jennifer. Yes, we can hear you.
Oh, fantastic.
Tim, you had a question for Jennifer.
Yeah, so Jennifer, I'm just going to ask you one question. I know we're coming near the end of time, but it's an important question. So the PPP loan, the Paycheck Protection Act, has been very helpful to people like my practice. And I know my banker as well, and I'm in a town where I know folks. But in a lot of areas, in New York City, New Jersey, practices have had trouble getting those loans because there's been other people ahead of them in line because they knew the banks. The two questions that came from the audience was, is there any liability the bank may have for not really producing those loans? And secondly, what can they do legally to help themselves in those situations?
Sure. So I think no bank is guaranteed. They may have given you a wink, wink, nod, nod front of the line, which I think a lot of us were hearing, but the reality is the bank had no control over the system. You could try to make a claim against the bank, but I don't know what kind of certitude you received that we might be able to take that for an actual lawsuit. I think more realistic is any of us who's not received, or all of us as a community, should be pressuring on our legislature to make available additional funds so that way the people who are supposed to get the money do receive it. The counter to that for the healthcare community is that part of the stimulus money from the CARES Act, $100 billion worth of, has come through HHS, through the Medicare system. So I would implore everyone who has not already, if you did receive the first tranche of funding, which is automatic, number one, please make sure you do certify so you can keep that grant. And then secondarily, please do what you can to receive your additional portion of the $20 billion allotment that's now available. That has not been expended yet to my knowledge base, and I want to make sure that everyone on the line does qualify who can. So please, if you don't know about that, I think we did cover part of it today, but if not, I can send out some information through the society on where to file for that.
Ken, just one.
No, that's a great answer. Very, very, very helpful answer. Thank you for that. And I think Chris has a question as well. Christopher.
Yeah, probably a final question, Jen. One of our panelists brought up the concept of risk stratification of our staff that gets into the medical history, which becomes a different type of relationship with the physician that's hiring them. And the concept came about getting a third party involved. What are your thoughts on risk stratification, medical risk stratification of the staff, and how do we approach that legally?
Well, I'm actually coming at it from a different realm, of course, as the attorney. I prefer not to get involved in the past medical history of the employees if they do not want to disclose. If I'd rather have them certify that they've notified us if they are high risk or not, and have them sign off on that. And then you're certainly going to be putting into place screening protocols, and that's going to be for everyone across the board. We're not going to discriminate in how we deploy those protocols. And I would not get a third-party medical examiner involved. I would not necessarily require. I think that if you think they're not well and you're screening and sending them home, that's going to be one thing. But coming back in high risk, I would rather that they self-certify.
So, how do you feel about getting them moved to a different part of the office to minimize their risk with their consent?
Right. Well, that also depends. I mean, I'm very cognizant of the fact that many of you are running businesses, and unfortunately, I hate to say it this way, but not charities. So if you can repurpose them, then that's fantastic. If you cannot, because you do not have the capacity in the office, or the person's skill set does not transfer, then I think the individual needs to make their own decision. You know, COVID-19 right now is not going to be a covered disability. You can try to provide reasonable accommodation, but if you cannot and the individual says it's impossible for them to come back to work, there may have to be a parting of ways.
Thank you very much, Jennifer. This was very helpful. Here, I want to take a little pause and thank our sponsors. This webinar is possible because of the sponsorship from Medtronic and SPR, and that is very, very helpful. Without, it's not possible without their support. I also want to thank my colleagues, Tim Deere and Chris Garibo. You have been wonderful always to support me, help me, whatever we do, and I don't have enough words to thank you both. And again, going back to our panelists, we had outstanding physicians, experts in their field, took their time. Some of them are very, very busy doing the webinars, but still took time and gave us a preference. So yes, thank you very much, and your support and everything you do to help us. I would like to also thank these two wonderful, beautiful ladies. They always work behind the screen. We don't know how much work they put in to make us successful. Thank you, Michelle, and thank you, Sandra. And with that, I would like to again thank our healthcare workers, frontline workers, putting their life at risk and try to help us and try to help their patients. So we have no words to appreciate their heroic work. So thank you again, and everybody have a good evening.
Thank you and good night.
Good night.
Good night.
Thank you. Good night.